Hi, this is Kristen Hannebauer. I am presenting on the infant mortality rate for Nursing 405, Nursing Profession and Healthcare Delivery from Murray State University. Today is December 29th, 2015, and this is for Dr. Carol Murch's class. My objectives for this presentation are that nurses will be able to state the importance of prenatal care and screenings in the process of decreasing infant mortality, and nurses will be able to use the information provided to advocate for their patient's care independent of the patient's social status or insurance coverage. The problem is that across the nation there were an estimated 6.05 deaths per every 1,000 live births in 2013. In Kentucky, in 2010, there were approximately 6.5 deaths per 1,000 live births of white babies and 12.5 deaths per 1,000 live births for black babies. With this information, there is a correlation between infant mortality and insurance coverage, because at the same time of this study, 19% of white women were uninsured and 30% of black women were uninsured. Most of these deaths were attributed to risk factors that can and should be addressed during the mother's prenatal care. Common causes of death include infection, low birth weight, and early delivery. Most of the infections or abnormalities that can cause infant death have early warning signs that can diagnose the problem. With adequate screenings from ultrasounds, blood work, and non-invasive prenatal testing, infection and abnormalities can be diagnosed earlier, leading to quicker action by a physician. Chromosomal abnormalities can be screened for, such as trisomy 18 or trisomy 13, along with open spina bifida or other open neural tube defects. If a baby screens positive for certain abnormalities, then the physician will be able to determine at this time if the baby needs to be delivered at a tertiary care facility that offers neonatal surgery or a higher level NICU. While not all of the conditions that can be screened for can be altered or cured, having the information can greatly improve the outcome of the infant. Per ACOG, patients with a high risk for low birth weight or short gestation are moms with preeclampsia or diabetes, infants with chromosomal abnormalities such as Down syndrome, trisomy 18, or trisomy 13, shortened cervix before 24 weeks gestation, multiple pregnancies such as twins or triplets, other complications such as altered blood flow to the infant, intrauterine growth restrictions which will cause low birth weight, and a history of preterm delivery. And this is per ACOG, the American Congress of Obstetricians and Gynecologists. In 2014, the Affordable Care Act was initiated, and since then, the government has worked to improve care for women. Before the Affordable Care Act, there was gender stereotyping, which caused insurance prices to be higher for women, or for the insurance to offer no maternity care at all. The downfall of the Affordable Care Act is that there are still uninsured or underinsured women. Before the act was instituted in 2014, 20% of women were uninsured and 16% were living in poverty. That was for white women. But the black population, it was even higher at 28.9% who were living in poverty and 19% that were still uninsured. There are studies that show that uninsured patients have higher mortality risk. And a high-risk pregnancy with a high history of preterm labor, preterm birth, gestational diabetes, or preeclampsia with or without the onset of HELLP syndrome, which is a type of severe preeclampsia characterized by hemolysis, elevated liver functions, and low platelet counts. There's a much higher risk that the mother will develop the same condition again. In a study conducted in 2013, there was a much higher mortality rate of infants that were considered uninsured, either with no insurance or on public aid like Medicaid. In another study conducted in 2009, a group to help high-risk mothers afford care showed that there were less than half the amount of low-weight or premature babies than that of the regular population. Findings from this study support use of outreach and enrollment strategies to reduce barriers to access to health care and reduce health disparities of low-income, vulnerable populations. Babies who are born less than 1,500 grams will require extensive medical treatment that will cost large amounts of money. These babies will need months of NICU time and follow-up after discharge. In Kentucky, roughly around 30% of households in a 2010 study were headed by single women, and during the same time there was a limited policy for women seeking Medicaid assistance. If babies are affected in utero by infection or delivered early due to maternal complications, they stand a higher likelihood of preterm birth, low birth weight, and abnormalities that are painful and will inevitably cause death. The impact on nurses. Nurses are the front line when it comes to patients, so when an infant dies, it is the nurse that is directly affected emotionally along with the family. Nurses will be the one with the family when the infant dies, and will be the one doing much of the explaining and the teaching. Many times it is the nurse's job to offer photography or create mementos for the family when they no longer have their baby. Making personal connections with the families and their children and then being the one to care for them after the death of their child is emotionally taxing to the nurse. I interviewed Kathy Gerhardt, who's a RN who works at St. Mary's Maternal Fetal Medicine and Genetics Counselor, and she says that even after 45 years of experience, every death is still just as hard as the last. According to Gerhardt, there's no way to plan for a death of an infant, and there's no good way to comfort the families, and the healthcare professionals that are in direct care with them are just as affected as anyone else. I've been a nurse for 2.5 years. I worked oncology and comfort care for the first 2 years, and I have worked with high-risk pregnancies for a little over 5 months. I've always been interested in high-risk cases and end-of-life care. I have worked with dying patients a lot over the past 2.5 years, most of them being adults. But with my new position, I am working with high-risk moms, some who themselves have life-threatening conditions, and their high-risk babies, who could also be born with life-threatening conditions. It's a lot harder situation to work with babies that will not survive or will have little quality of life after birth. It's hard knowing that these infants have not had any life and haven't done anything to deserve this. Each death feels like a personal loss for myself and my coworkers. I wrote a letter to Kentucky Representative Suzanne Miles. I sent her a letter via email, and she replied to me. I included information about poor insurance coverage by parents and it preventing the mothers and babies from getting adequate care, and what this could mean to the baby's health and to the mother's health. She did respond to me and agreed to keep this information in mind if faced with making a decision related to this. And these are my references. Thank you.